Hello, everyone. How are you all? So it's Dr. Nabira here. Again, we will do some question practice over here regarding the surgery topic and any of the questions you guys have regarding the AMC, regarding the exam, regarding the course. So we will be able to help you by every aspect. Again,
Hi,
it's an
Dr. Nabira.
interactive. Yes. Hello, Asma. How are you?
I'm fine. Hope you're doing great as well. So I guess we can wait for like 10 minutes so that all the students can join in and then we can start the session. What do you say?
Yes, sure. Why not?
Okay, that's perfect. So let's wait for 10 more minutes so that all the students can join in and then we can start the webinar properly. Hi, Dr. Nabira.
Hello, Asma.
Yes, we can start the session now. I guess all the students have joined in, so we can start now. Thank you.
Yes, sure. Okay, so we will start our session with today some surgery questions, some interesting questions, and most of the people have so much query regarding the surgery question, right? So we will discuss today, and it's a completely interactive session. So you have to answer it. Either you can type, either you can say in voice. It's just because arranged for you guys. So please participate in it and let your query clear. Okay, so we'll start with the surgery question. 48-year-old woman developed constipation postoperatively and self-medicates with milk of magnesia. She presents to clinic at which time her serum electrolytes are checked and she is noted to have an elevated magnesium level. Which of the following represent the earliest clinical indication of hypermagnesia? Is my screen available to everyone?
Yes, we can see your screen.
Okay. Come on, everyone, let's answer the question. I guess everyone answered the right, so shall move to the explanation. So most of the people get the right answer. The answer is loss of deep tendon reflexes. Why? Because this is the earliest indication of hypermagnesia. States of magnesium excess are characterized by generalized neuromuscular depression. Clinically severe hypermagnesia is rarely seen except in those with advanced renal failure treated with magnesium containing antacid. However, magnesium is produced intentionally by obstetricians who use parenteral magnesium sulfate to treat preeclampsia. So remember that it is not necessary that they will give you a simple scenario. They can even give you the scenario related to the preeclampsia as well. Magnesium sulfate is administered until depression of the deep tendon reflexes is observed, a deficit that occurs with modest hypermagnesia, that will be the 4 MEQ per liter. Greater elevation of magnesium produces progressive weakness, which culminates in flaccid quadriplegia and in some cases respiratory arrest due to paralysis of chest parose muscles. Hypotension may be occur because of the direct arteriolar reflexing effect of magnesium, right? Changes in mental status occur in the late stage of the syndrome and are characterized by somnolence that progresses to coma. So you need to see that I just talk about the two things. One is regarding the hypermagnesium state in preeclampsia and another is renal failure. So scenario can be given regarding the renal failure or regarding the preeclampsia. You need to choose the right answer, the earliest clinical manifestation, the next manifestation, and will be the manifestation of the choice. Okay, so the next question is 75-year-old man with a history of MI 2 years back, peripheral vascular disease with symptoms of claudication after walking half a block, hypertension and diabetes present with a large ventricle hernia. He wishes to have the hernia repaired. Which of the following is the most appropriate next step in his preoperative workup? Anyone? Okay, one thing I want to know that a person who is already having so many diseases, you are just going with a ECG only because it's a pre-workup we are doing, right? And those who are selecting the option E, why you are going not for any further testing? This patient has lots of comorbs, so I guess this patient has a more indication for any other test as well. Okay, now I guess most of the people will answer it. Shall we move to the answer? Only three doctors give the right answer. So the answer is D. As you see, the patient should undergo peristenian thallium stress testing followed by echocardiography to assess his need for coronary angiogram with possible need for angioplasty, stenting, or surgical revascularization prior to of his hernia. As you see, this patient already is having diabetes, already having claudication, having multiple comorbs. So in this type of case, how you can only proceed with the ECG? For my question is this first to everyone, right? Although exercise stress testing is appropriate method for evaluating a patient cardiac function preoperatively, this patient's functioning status is limited by his PAD. Therefore, a pharmacological stress test would be preferred method of cardiac evaluation. An ECG should be performed in this patient with a history of cardiovascular disease, hypertension, and diabetes, but a normal ECG could not preclude further workup. So that's why we are just going with the stress test as well. While MI within 6 months of surgery is considered to an increased risk of cardiac complication after surgery using Goldman criteria. A remote history of MI is not prohibited for surgery in and of itself. So just because of the claudication, lots of comorbs, we need to rule out the stressor as well because ECG cannot even preclude the other comorbs and other conditions that will require for the repair of hernia. So we need to go for ECG as well as the stress test to see either the patient is an able or is suitable for the operation or not. Okay, a 78-year-old man with a history of coronary artery disease and an asymptomatic reducible inguinal hernia requests an elective hernia repair. Which of the following would be a valid reason for delaying the proposed surgery? Come on, everyone, let's participate in this. It's just a free session just because of you all guys to participate and clear your queries, right? Okay, I guess only few doctors give the right answer and most of the doctors give the incorrect answer. So the answer is C, that will be the jugular venous distension. Why? Because the work of Goldman and others has served to identify risk factors for perioperative MI, right? The highest likelihood is associated with recent MI infarction. The more recent the event, the higher the risk up to 6 months. It should be noted, however, that the risk never returns to the normal. A non-Q wave infarction may not have destroyed much myocardium, but it leaves the surrounding area with borderline perfusion. Thus, the particularly high risk of subsequent perioperative infarction, evidence of congestive heart failure such as jugular venous distension, S3 gallop, also carries a high risk, as does the frequency occurrence of ectopic beats. Older age greater than 70 years and emergency surgery are risk factor for independent of these others. So the answer will be go for the jugular venous distension. Because coronary revascularization by coronary artery bigraph, we can say cabbage, tends to protect against MI. Smoking, diabetic, hypertension, and hyperlipidemia are surprisingly not independent risk factor. Although they may increase the death rate, should as an infarct, but these are not the particular factors that we can even postpone or delay the surgery or something. The value of this information and data derived from further testing is that it's identified the patient who needs to be monitored invasively with a systemic arterial catheter and pulmonary arterial catheter. Most perioperative infarcts occur postoperatively when the third space fluids return to the circulation, which increases the preload and the MI oxygen consumption. So this generally occurs around the third postoperative day. So among them, our answer will be the jugular venous distension. Okay, a 30-year-old woman in her last trimester of pregnancy suddenly developed massive swelling of the left lower extremity. Which of the following would be the most appropriate workup and treatment at this time? Okay, it's my general question to everyone that why you guys are not going for venal cable filter? Anyone who knows the answer, just write in the chat box. Okay, very good. So I guess most of you answered it correctly. The answer will be the B. That will be duplex ultrasound and heparin, because duplex ultrasound is the diagnostic modality of choice for detection of infrainguinal DVT. Although venography is the gold standard, it is no longer routinely used given the risk of local thrombosis, pain, and contrast-related allergic reaction and renal failure complications. Impedance epithelioscopy, which measures changes in volume in the lower extremities as related to blood flow, is also an infrequent due to superiority of Doppler scanning in the detecting of DVTs. So in pregnant women, anticoagulants for treatment of DVT is achieved with heparin, which does not cross the placenta. This is the main reason. Those who are typing or marking the warfarin, we cannot even give the warfarin because it can cross the placenta, right? Rather than warfarin, which is associated with risk of spontaneous abortion and birth defect. The venal cable filter is not indicated because there is no contraindication to heparin therapy and no evidence of failure of anticoagulant therapy. See, this is the reason that why you cannot even give the cable filter. Okay, a 65-year-old man undergoes a lower anterior resection for rectal cancer on the 5th day in hospital. His physical examination shows a temperature of 39, that will be the 102 fever, blood pressure of 150 by 90 mmHg, pulse of 110 beats per minute and regular, and respiratory rate of 28 breaths per minute. A CT scan of the abdomen reveals an abscess in the pelvis. Which of the following most accurately describe his present condition? I guess only 2 or 3 doctors gave the right answer. I want everyone to participate in it. So just you need to be clear with the concepts, with the questions. Those people who answer the septic shock, does this criteria match for the septic shock? Okay, now we will move to the answer. So only few doctors give this answer. The answer is B, that will be the sepsis. So the correct diagnosis is sepsis. Why? Because SIRs involve 2 or more of the following. Number 1, that will be temperature greater than 100 or beat 90 per minute, respiratory rate greater than 20, or PaCO2 will be 12,000 or 10% of immature neutrophils. For the sepsis, we will say that SIRs plus documented infection. So in the question, they mentioned there will be a abscess. So that will be the sepsis. Severe sepsis will be sepsis plus organ dysfunction or hypoperfusion. So there will be no ALOC in the question. There will be no organ dysfunction, or there will be no such oliguria or acidosis or any kind of thing that will show that organ dysfunction is happening. Septic shock will be sepsis plus organ dysfunction plus hypotension. That will be systolic blood pressure 90 mmHg with vasopressors. So these are the criteria to differentiate between sepsis, SIRs, septic shock, and the severe sepsis. Okay, A 65-year-old woman has a life-threatening pulmonary embolus 5 days following removal of a uterine malignancy. She is immediately heparinized and maintained in good therapeutic range for the next 3 days. Then passes gross blood from her vagina and develops tachycardia, hypotension, and oliguria. Following resuscitation and abdominal CT scan reveal a major retroperitoneal hematoma. Which of the following is the best next step in the management? Okay, those who are answering the question B, I want to know that a patient if came in emergency setting, why your first most goal is that you will evacuate the hematoma. I guess before that there will be lots of things you need to do first, and then you will go for the evacuation of hematoma, right? Okay, those answering E, don't you guys correct the thing that has happened already? Like that's correct that you stop heparin or something, but don't you want to correct it? Like if we have an antidote for this, so why don't we go for that? Okay, for the answer is A, we can immediately reverse of heparin anticoagulant is indicated in a heparinized patient with significant life-threatening hemorrhage, right? Protamine sulfate is a specific antidote to heparin and is given at 1 mg for each 100 units heparin. It is given in cases when hemorrhages begin shortly after a bolus of heparin. For a patient who is undergoing heparin therapy, the dose should be based on the half-life of heparin. Since protamine is an anticoagulant, only half the calculating circulated heparin should be reversed, right? The indications for inferior vena cava filter placement fall into 3 categories. Number 1 is a failure or complication of anticoagulant, a known free-floating venous clot, and a prior history of pulmonary embolism. In this critically ill patient, exploration of the retroperitoneal space would be surgically challenging and unnecessary. Like if you open it and just want to evacuate it, it will be spilling it more and patient will be go definitely in the shock. So we cannot open or evacuate it. The foremost thing is what we need to do is we need to reverse the effect. This is the foremost case in this question. And this question came in the exam from the pictorial point of view as well, that they give a picture of a MRI, and this was the retroperitoneal hemorrhage was done over there, and they will ask you that what would be the treatment or how you can treat the patient. So I just asked this question in a form of just explanation and writing instead of the pictorial. So you need to know that what you will do rather than evacuation of the hematoma. Okay, 63-year-old man with a history of poorly controlled diabetes present with right leg swelling and pain. The patient denies trauma to the leg and reported was normal yesterday. Examination of the right lower extremity is significant for extreme tenderness to palpitation, erythema, and edema extending up to the knee. X-ray of the right leg showed tissue swelling without gas or osteomyelitis. The patient's vital signs are normal and he started on IV broad-spectrum antibiotic and insulin. An hour later, the patient's heart rate increased to 125 and the erythema has progressed to the thigh and with new blister formation of the leg. Which of the following most appropriate next step in the management? Anyone? Those who can answer it, just first let me know what is your diagnosis over here. Because once you know the diagnosis, you can easily crack the question. A doctor in cellulitis, does we open the patient? Very good. Only one or two doctor give the right answer. Your diagnosis is correct. Now give me the answer how you will manage this patient. Very good. So this is a case of necrotizing soft tissue infection. The rapid progression of the erythema, bulla formation, and the tachycardia mandates immediate surgical intervention. During surgery, an incision is made overlying the area of suspiciousness, and the deep soft tissue, fascia, and underlying muscles are directly visualized. All affected areas are completely resected. The radiological studies should not be undertaken in patient whom the diagnosis is seriously considered, as the delay surgical intervention and often provide confusing information. Similar question was given in the AMC, but they are giving you the diagnostic tools like you will go for the X-ray, either you will go for the ultrasound, or you will go for the CT scan, and in the last they put the option that you will go to the directly surgical intervention. So most of the people, because they similarly think that it's cellulitis, so they just go for the ultrasound, right? But that was not the true, because in these type of cases, that's very obvious. You are getting all signs of the necrotizing fasciitis. So what you need to do is just go for the surgical intervention right away. So make sure if they are confuse you with giving the radiological studies and give you the interventional studies as well, you need to see the question that what they are asking. And then you need to answer it. Okay, 25-year-old man is brought to the emergency room after sustaining burns during a fire in his apartment. He has blistering and erythema of his face, left upper extremity, and chest. He also has circumferential fracturing up his right upper extremity with decreased capillary refill. He is agitated, hypotensive, and tachycardic. Which of the following is the most appropriate initial management of his wound? Okay, those who are answering the A, in this case, how you can apply the topical antibiotic, and I want to know that which degree of burn is this? And can you directly apply the antibiotic on the burn wound? Anyone can answer which degree of burn is this in this case? Very good. One thing is that there are multiple burns in this patient, right? So we cannot even apply anybody who can answer or like someone answer over there that antibiotic. We cannot directly apply the antibiotic on this because there are some circumferential burn, there are some deep burns, lots of burn, multiple burn over there. So in this case, what we do is we will go for the option C. Like medical is attention to deep circumferential burn and crucial is management of burns patient. Progressive tissue edema may lead to progressive vascular and neurological compromises because the blood supply is the initial system affected. Frequent assessment of flow is vital with longitudinal hysterectomy performed at the first sign of vascular compromise. A low threshold should be maintained in performing an hysterectomy in the setting of severely burned limbs. Burn wound management is characterized by early excision of areas of dead cartilage tissue, with the exception of deep wounds of the palms, soles, genitals, and face. Stage excision of deep partial thickness or full thickness burn occur between 3 and 7 days after the injury. Okay, there are several proven advantages to early excision, including decreased hospital stay and lower costs. So this is especially true for burns encompassing up to the 30 to 40% of total body surface area, which is exactly happen in this scenario. In conjugation with early excision, topical antimicrobials such as silver sulfadiazine are extremely important in delaying colonization of the newly excised or fresh burn wounds. So this will be the second line of treatment. In this case, it is not the first line of treatment. Permanent coverage through split thickness skin graft usually occurs more than 1 week after injury. Skin autograft requires a vascular bed and therefore cannot be placed over scar. So you cannot even go for directly antibiotic. What you need to do is just because third degree burn will definitely go for the vascular compromise. So you need to save the patient. For this, you need to do the hysterectomy to save the other tissues that are vitalized, that are not dead right now. Moving to the next question, a 12-year-old boy is in a motor vehicle collision in which the car caught fire. He sustained significant inhalation injury and a circumferential burn without fracture of the other soft tissue trauma to his left lower extremity during extrication from the burning vehicle. He is intubated and aggressively resuscitated in the intensive care unit. Which of the following most appropriately method of assessing for compartment syndrome of the left lower extremity? Doctor, is it possible for you to do the MRI of a patient who is not in even a state of consciousness or something? Okay, the first thing in this question is this person has already developed compartment syndrome, right? Now they are asking that how you can assess this patient for the compartment syndrome. Okay, I guess few of you get the right answer. The thing is that we uh, we can even assess, we can even determine the compartment syndrome only clinical examination, right? What we are seeing in this patient is what the arterial flow or pulses. That either it is working, either it is not. We can palpate it. For this reason, we need to do is Doppler. This is the question what they are asking. They are not asking for the compartment syndrome identification or something, because compartment syndrome, as I told you, we just do clinical testing, and on the basis of that, we just surgically intervene it. But for the checking of pulse, either it is palpated, either it is having flow or not, we need to use the Doppler. Because compartment pressure can also be measured with a pressure greater than 40 mmHg being diagnostic. And compartment syndrome secondary to burn are as a result of increased pressure, secondary to tissue edema, and lack of elasticity of the burn skin, causing compression of blood vessels. So when they compress the blood vessels, we need to check either the flow is coming or not. For this, the diagnostic is only the Doppler. Other modalities, CT, MRI, angiogram, we cannot even the diagnostic. And also in this type of patient who is in BiPAP or something and is in on ICU, we cannot go for the MRI. Like it's the logical if you think like that in a way as well. Okay, shall we move to the next? 65-year-old man who smokes cigarettes and has chronic obstructive pulmonary disease falls and fractured the third, fourth, and fifth in the left anterolateral chest. Chest X-ray is otherwise normal. Which of the following would be most appropriate next step in the management? I just removed the very favorite option from the scenario just to see that what will be the next step. Like if there will be a CPAP or something and putting the patient on vent, that you will get the question, right? So I just exclude that option. So what will be the next step? Okay, those who are saying that B, it's very obvious. The person who is having multiple rib fracture, we cannot send the patient to home directly. It's very obvious. So option B is excluded. And another logical thing is that do you see a person who is having so much fracture of the lips can be satisfies or can be with good with oral analgesics? Okay, those who are going for the option C, is there anything that is mentioning about the pneumothorax, hemothorax, or any type of trauma that causes the patient to develop any type of traumatic injury. Like there is no comment about any chest X-ray or anything. Like they say that chest X-ray is normal. So there is no pleural effusion, pneumothorax, hemothorax, or something like that. So how you can approach this patient? Also, the thing is that he's fragile, 65 years of age. Do you counsel him with the oral analgesics? In 65-year-old male who is already having fracture and everything was going on, can you go for the surgical fixation like anesthesia fitness? Might be he will not be able to go fit for anesthesia. Okay, so this is what AMC play with your mind. They ask the most appropriate next step. For most, the next step, every time when the patient came with injury or something, you need to subside the pain. So D is the right option over here. Because when the three ribs are fractured from different angles, you cannot even counsel the patient or satisfy the patient with oral painkillers. Patient with lower rib fractures may have associated abdominal injuries, should undergo a prepared evaluation like ultrasound fast, CT scan, or peritoneal lavage. Epidural catheters, continuous narcotic infusion, and patient control analgesics are the most effective method for ensuring pain control in hospitalized patient with rib fracture. Patients who are elderly, have multiple rib fracture, demonstrate ventilatory compromise, or have underlying respiratory problems, such as in this case, COPD or smoking, are at increased risk for pulmonary complication like atelectasis, pneumonia, respiratory failure, and should be hospitalized. Patients with minor fracture injuries and no significant comorbs may be managed at home with oral analgesics and appropriate instruction for coughing and deep breathing. Attempt to relieve pain by immobilization and splinting, such as strapping the chest, merely compound the problem of inadequate ventilation. And in old age, we cannot even strap the chest. Tube thoracostomy is indicated only if pneumothorax is diagnosed. Intercostal nerve block often provide prolonged period of pain relief, but have largely replaced by epidural catheters and IV narcotic administrations. So rib fractures heal spontaneously without need for surgical intervention. Whenever the patient came with the pain, the first and foremost goal is you need to subside the pain because investigation, treatment will be ongoing. But what you need to do is patient is always yelling and just in a grimace just because of the pain. So you need to subside the patient's pain first. Okay, so the next question is 45-year-old man was an unhelmeted motorcyclist involved in a high-speed collision. He was ejected from the motorcycle and was noted to be apneic at the scene. After being intubated, he was brought to the ER, where he is noted to have a left dilated pupil that respond only sluggishly. What is the pathophysiology of his dilated pupil? I just put the word like pathophysiology, but in the past papers, similar scenario with the word that what will be the cause of his dilated pupil or what will be the pathology that leads to the dilated pupil. That what's the incident over there happen that leads to the dilated pupil. In simple words, we can say that which area of the brain that hits and causes this symptom. Okay, great. I guess everyone gave the right answer about it. So increasing intracranial pressure tend to displace brain tissue away from the source of the pressure. So if the pressure is sufficient, herniation of the ulnar process through the tentorium cerebri occurs. Pupillary dilation is caused by compression of the ipsilateral motor nerve and its parasympathetic fibers. If the pressure is not relieved, the brainstem will herniate through the foramen magnum and cause death. Hypertension and bradycardia are pre-terminal events. Very good about it. Next question is 23-year-old previously healthy male present to the ER after sustaining a single gunshot wound to the left chest. The entrance wound is 3 centimeter inferior to the nipple and the exit wound is just below the scapula. A chest tube is placed that drains 400 ml of blood and continues to drain 50 to 75 ml per hour during the initial resuscitation. Initial blood pressure of 70, I guess I just forget to mention the value. 70 mmHg has responded to 2-liter crystalloid and is now 100 by 70. Abdomen examination is unremarkable. Chest X-ray reveals a re-expanded lung and no free air under the diaphragm. Which of the following is the best next step in the management? Up till now, no one gave the right answer. I'm astonished. Okay, so the right answer is D. We will go for exploratory ciliotomy because gunshot wounds to the lower chest are often associated with intra-abdominal injuries. Any patient with a gunshot wound below the level of T4 should be subjected to abdominal exploration. The domes of the diaphragm are at the level of nipples and the diaphragm can rises up to the level of T4 during maximum respiration. Exploratory thoracotomy is not automatically indicated because most parenchymal lung injury will stop bleeding and heal spontaneously with tube thoracostomy alone. Indication for thoracic exploration for bleeding are 500 ml of blood on initial chest tube placement or persistent bleeding at a rate of 200 ml per hour for 4 hours or 100 ml hour for 8 hours. Peritoneal lavage is not indicated even when the abdominal examination is unremarkable. As many as 25% of patients with negative physical examination and negative peritoneal lavage will have significant intra-abdominal injuries in this setting. So these injuries include damage to the colon, kidney, pancreas, aorta, and diaphragm. Local wound exploration is not recommended because the determination of diaphragmatic injury with this technique is unreliable. So the answer will be the exploratory ciliotomy, or there will be in the option exploratory laparotomy that will be more pronounced because there will be intra-abdominal injuries, not the intrathoracic. So the AMC can change the options. You need to stick with the logic. You need to stick that which mechanism of injury is happening and which will be the anatomical site or areas. Another question is 42-year-old man is undergoing chemotherapy after resection of a cecal adenocarcinoma with positive lymph nodes. You're asked to see him regarding a potential surgical complication. Which of the following potential operable complication is a common occurrence among patients receiving systemic chemotherapy? Okay, I guess only two doctors gave the right answer and very good. The most commonly complication regarding is we go for the surgical operative intervention is perirectal abscess. A surgeon is frequently asked to evaluate patients who are receiving systemic chemotherapy. Most complications of chemotherapy do not require surgical therapy. Perirectal abscesses are more common in these immunocompromised patients. GI bleeding occurs secondary to mucosal irritation and thrombocytopenia. Pancreatitis is uncommon but is associated with L-asparginase use in up to 20% of patients treated with fluoxetine by continuous hepatic artery infusion develops some degree of inflammation and obstruction of the bile duct. Systemic chemotherapy does not increase the likelihood of acute cholecystitis, appendicitis, and incarcerated femoral hernia or diverticulitis. So perirectal abscess will be the most common. Just for the sake of, we will go for surgical intervention. Okay, the second last question. 35-year-old woman presented with a lump in the left breast. Her family history is negative for breast cancer. On examination, the mass is rubbery, mobile, and non-tender to palpate. There are no overlying skin changes and axilla is negative for lymphadenopathy. An ultrasound demonstrates a simple 1 centimeter cyst in the area of the palpable mass in the left breast. Which of the following presentation the most appropriate management of this patient? Anyone? Okay, so I guess a few of you give the right answer. The answer is A. We will reassure and re-examination. Most clinicians would recommend reassurance and re-examination in this situation. Cysts are common lesions in the breast of women in their 30s and 40s and carry a very low risk for malignancy. A simple cyst is almost never associated with malignancy. A complex cyst may be associated with an underlying malignancy and aspiration is usually recommended. If the cyst disappears with aspiration and contents are not grossly bloody, the fluid does not need to be sent for cytologic analysis. If the lesion does not completely disappear or reoccur multiple times after aspiration, the fluid should be sent for cytology. Excision of a cyst is indicated only if the cytological findings are suspicion for malignancy. In young women like this, the breast parenchyma is dense, which limit the diagnostic value of mammography. A fluoroscopy guided needle localization biopsy is reserved for non-pebble solid lesions of the breast. So moving with the last question for the regarding the surgery, a 33-year-old pregnant woman notices a persistent painless lump in the left breast. On examination, left breast has a single mobile mass without evidence of a skin change or lymphadenopathy in the neck or axilla. An ultrasound demonstrate a solid 1 centimeter mass in the upper outer quadrant of the breast. A core needle biopsy show invasive ductal carcinoma. The patient is in her first trimester of pregnancy. So which of the following most appropriate management for this patient? Okay, I guess most of you give the answer incorrect. Why you guys are going for modified radical mastectomy? The answer is D. This patient don't develop the CA right now, but this patient is already having the Paget disease of the breast until proven otherwise. Though with a thorough workup for the breast cancer, she needs a mammography and a biopsy of the affected area. Paget disease of the breast present as a small percentage of all breast cancer and is thought to originate in the retroareolar lactiferous ducts. It progresses towards the nipple-areolar complex in most patients, where it causes the typical clinical finding of nipple eczema and erosion. Up to 50% of patients with Paget disease have an associated breast mass. Nipple-areolar disease alone with represent in cancer. These patients have a 10-year survival rate over 80%. In contrast, if Paget disease is present with the mass is likely to be an infiltrating ductal cancer. The generally recommended surgical procedure for Paget disease is currently a modified radical mastectomy. Watchful wearing steroid creams and antibiotics are not appropriate forms of management in a woman who present with a rash involving the nipples. So along with this, we just covered this little bit of surgery questions, and it's a good discussion with you guys. I hope it's very useful for you and you like the session. Any query up till now or any question regarding it, you can ask me and the team med expert as well. So yeah.
Thank you so much, Dr. Nabira, for this informative session. I can see a lot of familiar students in this today's session. We have Dr. MP Singh, Dr. Arvind, Dr. Daniel, Dr. Diana. How are you all? So I will just take your 15 to 20 minutes just to update you about the new upcoming courses so that you can start your AMC preparation. So I am referring to those students who are planning to sit for 2025 exams starting from February. So what you can do is you can start your preparation with us. And what we do is we offer multiple courses for your best preparation of AMC. Okay, because it's not a very easy exam. Yes, it is a tricky exam, but with right strategy, with right panel of mentors, you can ace your AMC exam. Because nobody wants to appear again and again. Everybody wants to appear one time and get through this exam. So with this right approach, what you can do is you can clear your exam. We can guarantee you this thing, because what we are doing is we are providing you the right guidance with right mentors and with right content of the material that you can use to pass your exams. Okay, so now let me just briefly tell you about the courses that we are offering. So for all the students out there who have done with their theory part or are good with their basic knowledge, so we are launching our recall crash course that is basically for those students who want to practice questions. Like in this session, Dr. Nabira has discussed surgery questions with you so that you can get the insights how the questions will be in your exam day. So similarly, what you're going to do is we are going to help you practice each and every system from medicine, from surgery, from pediatrics, with every system out there, and practice as much as questions as you can. And with this recall crash course, we are going to provide you all the recalls of 2024, and that recalls will be day wise. Okay, let's suppose if we're going to give you the recalls of February month, we're going to give you 5-day recall files in which we are going to provide you the recorded sessions and PDF both, so that you can work on your basic knowledge, you can understand the recalls. So let's suppose if AMC changes the scenario, if the recall has been changed, so you can able to understand those recalls and solve those. Okay, so now let me just briefly tell you about the features of the recall crash course. we are going to provide you a question bank that will contain 5,000 plus questions that you can practice on the website along with correct answers and explanation. Okay. Then we're going to have 15 live sessions in which we are going to discuss topic-wise recalls, and we are going to discuss 2024 paper recalls as well with the most experienced mentors. Then we're going to provide you 3 mock exams to assess your preparation just before your real exam. And we are going to provide you the psychiatry workshop in which we're going to provide you 5 recorded sessions of psychiatry that are conducted by our experienced mentor, Dr. Nabira. And then we are going to provide you all the recall files of 2023 till 2024 so that you can practice as much as recalls as you can. Okay. So this is the schedule that we are going to conduct for the recall crash course. We are going to start module-wise preparation, starting from medicine, then surgery, then gynecology, then peds, then ops, then psychiatry, and then in the end, we're going to provide you the mock exam. So it will be a complete package for you. So for all the students who haven't started their preparation yet, what you can do is you can join us for the recall crash course and you can start your preparation with us. So this is the bundle offer that we are offering for all the students who have joined us today. We are giving the recall crash course plus the recall sessions that we are going to start from February. In every month, we're going to discuss that particular day exam paper. So you can decide your exam week month. You can let us know on 1 month. You can join like February, March, April, whenever you are appearing for the exam. You can join the package of recall crash course plus exam week session, and we can give you $100 off on that. And if you want to join us for the regular course, which is a 4-month course plan, you can join us for the regular course plus exam week session of any month of your choice, and we're going to give you $100 off for that as well. So now look at the amazing feedbacks of the students who have joined us and trusted us with our preparation. You can see the reviews, how they have expressed their emotion towards us. And these are the students who have joined us for the courses and they have passed the exams. So if you have any questions regarding anything, we're more than welcome to guide you, to help you out in your preparation. So if you have any other questions, you can write in the chat box. Dr. Nabira is also available. I'm also available to answer all your queries. Thank you so much. This was all from my side. I just wanted to give you the insights of the upcoming courses. So rest is all up to you.
Thank you so much, Asma, for such a nice briefing. Hope we see the students in our next recall session.
Yes, surely, surely. So we have given our numbers in the chat box. If you have any further questions, if you want to talk to us, you can just directly message us. We're always available for your guidance and support. So you can contact us and give us a call. We are more than welcome to guide you. So this was all for today's webinar. Thank you so much, Dr. Nabira, for your time. And let's end the session now. Thank you so much.